I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island community. Today's program is about stroke and stroke centers. Every year, about 800,000 strokes occur in the United States. It's the largest cause of disability in the United States and in the world. The cost is over $33 billion, and someone has a stroke every 40 seconds. It's my pleasure to have our wonderful guests here. And it feels like we have a stroke team at Richmond University Medical Center, and it feels like we're having our monthly meeting. So I wanted to introduce Patricia Abruzzese. She's a registered nurse. She's the stroke team coordinator from Richmond University Medical Center. And Dr. Matthew Kaufman, a trained emergency room doctor, and who's trained in emergency medicine. It's a pleasure to have you both. And to say I'm the chairman of the Department of Neurology and the medical director of the Stroke Center on Staten Island at Richmond University Medical Center, and actually had my hand in starting the first stroke center on Staten Island a number of years ago at Staten Island University Hospital. I actually helped organize it and founded it. So we have a lot of experience with stroke, and people want to know about stroke. Stroke is not something anymore where we just sit in a corner and don't do anything about, but we're much more aggressive with it. So maybe we can get started in saying, what are the signs of a stroke? How would someone in the community, how would someone know if someone has had a stroke, Matt?
Well, it can present a number of ways. A stroke can present a few different ways. The things that we concern ourselves about is weakness in an arm or a leg, drooping of the face. There are other symptoms too, dizziness and so forth. But there are a number of presentations.
And things, as you said, there are a lot of different presentations because the brain is a big place. It could be if it's on the left side of the brain, the right side of the body is involved. The right side, the left side. Double vision, blurred vision in one eye. People who get severe, intense headaches. But we're looking for anything, and the word stroke, and just by definition, means a stroke. It happens abruptly. It's an acute event. So the American Heart Association, wanting to get out to the community an idea that we need to treat stroke faster and be more aggressive with it, came up with a word FAST, an acronym. And Trish, maybe you could tell us a little bit about it.
The American, like you said, the American Stroke American Heart Association with FAST, basically what it means is they look for signs, a face, if there's some drooping on one side, as Dr. Kaufman had referred to, or an arm, if your arms, can you elevate your arms if one starts to fall down? And then speech is a very, very particular. Speech can be garbled, there can be difficulty with articulation of words, unable to formulate words, and the time is truly of T is for time is truly of essence to really contact 911. That is the first line of defense, getting EMS to that patient immediately to initiate care on that patient and get them to a facility.
And we're going to talk about this again and again during this program, the concept of time is brain.
Yes, sir.
The idea that if someone has a stroke-like symptom, as Dr. Kaufman and you mentioned, facial asymmetry, weakness in one arm, slurred speech, not understanding, it's crucial to get to a hospital as soon as possible.
Yes, sir.
We have certain windows of time. If someone gets there within 3 hours, we could do one thing. Within 6 hours, another thing. And after 6 to 12 hours, after 12 hours, there's really minimal intervention that we could do aggressively. There are things we could do, but it's very important that people get to the emergency room and get care. I think you mentioned to me, when someone has a stroke, what happens to their brain? How many nerve cells are involved?
They lose every minute about 1.9 neurons. Their brain actually ages 3 to 6 years in a short period of time for every hour that it goes untreated, a stroke goes untreated. So it really involves a lot of different mechanisms in your body. If we don't get attended to right away, it can cause a lot of damage.
So people lose 2 million nerve cells, neurons, every minute. That's a lot.
That's a lot.
I mean, we have a lot to start, and as a neurologist, I'm keenly aware of you need your nerve cells in order to think, and you said you age faster, so your memory is involved, speech is involved, but 2 million per minute of being untreated.
Yes, sir.
And what happens with a stroke is that the arteries that are going to a part of the brain close off, and we really don't get enough blood supply to that area. It's very similar to what happens in someone who has a heart attack. Someone with a heart attack, the arteries to the heart are involved. So the concept comes up right now about, we said what a stroke is, and we'll talk about that more in detail. But what's a stroke center? And you know we run a stroke center, so tell us a little bit about it.
A stroke center basically is a facility that deals directly with and provides quality care for our stroke patients. Each stroke center has a protocol to follow, which it emulates basically from American Heart, American Stroke, what has to be done in shorter periods of times regarding making sure medications are given, interventions and interdisciplinary teams and stuff to facilitate and help that patient get back to their ultimate status of functional status.
Right, so there's a lot of people involved.
Yes, sir.
So we're going to start from the very beginning. Matt works at the emergency room. He's a wonderful emergency room doctor, emergency medicine physician. And what happens if someone has a stroke and they call 911? And even if they think they have the stroke, they don't have to always be right. If you call in 911 and say I have slurred speech, what happens next?
So the emergency department may be notified actually by the ambulance, but the ambulance gets there, and usually that is part of the team identifies a concern that this patient may be having a stroke. I'm going to let the emergency doctors know, and as soon as they get there, they are prioritized as the highest. There is no higher priority for the emergency department functioning as a patient who might be having a stroke. We get them immediately to the CAT scan. We immediately take a certain specific set of bloods. A team of doctors and nurses assesses the patient, and we come up with a plan from there. And of course, as you know, the neurologist is called and consulted at that time as well.
So that's what happens when someone comes in with a stroke. And what's interesting at Richmond University Medical Center, which is very unique, is the CAT scan machine is actually in the emergency room. So many a time you'll just take a quick look at a patient and they'll go to CAT scan first in order to see if they or someone who might have had bleeding in their brain or a tumor or a seizure or something else that might look like a stroke. I mean, as we said, a stroke is a rapid onset neurological condition. So there are some other things that might look like it. So that's where the CAT scan is so important. So once you make a determination that someone had a stroke or looks like they're having a stroke, what's the next step? What do we look to figure out?
Again, getting back to the concept of time, this is a critical piece that we look at. When did those symptoms start, and how much time out from that are we? And so that window will determine which medicines, as you alluded to, we can give, which types of interventions, very specific to that time frame.
So let's go over one of the interventions, and this has been out there for about 15 or 20 years now, and it's called TPA, and TPA is tissue plasminogen activator. It's a kind of dissolving agent where many people who have a stroke have a clot, and that clot has to be dissolved. That clot is blocking blood from going to a certain part of the brain. That's what's leading to the symptoms of a stroke. The same way with a heart attack, the artery going to the heart is is closed off and not getting enough blood supply. That's why we get chest pain. But if you have a clot there, there's a possibility that in the first 3 hours, we can give a medicine in the emergency room called TPA, which will dissolve that clot. It's not for everyone. It's not for people who have very minimal deficits or who have bleeding in the brain. But in a lot of people, this will help them become functional. And what's interesting, if you look at the first, number one, the clot is there, and number two, the medicine is given, and then the clot dissolves, and then we're able to restore blood flow to that area. And even a little bit of blood flow will reduce the disability, the functional decline dramatically in a person. So being able to get people into the hospital early is important. Many people don't get to the hospital early. I think, Trish, you've told me at our last meeting less than 10% actually will be eligible even for TPA. Mm-hmm. Why don't you think people come to the hospital early enough?
I think they don't really recognize that they're actually having a stroke activity. Sometimes people have symptoms and then they go away or they resolve and they feel like you go wait and they go to sleep and then they wake up the next morning and they don't feel that well again. And then that starts the process of, maybe I have to go get checked out. So a lot of times not recognizing the actual signs of the stroke is a preventative that they don't come into facility.
So we can't emphasize enough that if you have slurred speech, weakness on one side, double vision, blurred vision, the thing to do is not take a nap and go to sleep. The thing is to get health care.
Yes. Is
to go to the emergency room where people like Dr. Kaufman are there, and they call the neurologists who are heavily involved, and I'm heavily involved with the stroke team as director, to see if there's a treatment that could be given at our hospital or something else. There's a lot of new treatments that are coming out right now for stroke, but the idea that we're not using many of our treatments that we have because people don't get to the hospital soon enough is something that's very, very difficult and very hard for us to understand. And stroke is where heart disease was a number of years ago. People had heart problems and would say it's indigestion. Now, because of the American Heart Association and education, people know that if even after they have a large meal and they have some pain in their chest or upper stomach area, they have to go to the hospital. People are learning that much more. So let's talk about when someone gets admitted to the hospital. They go into a stroke unit, a stroke care center. Who's there? I mean, as we keep on talking about this team, the emergency room doctors, maybe you can just flesh out who is actually part of this team.
We have a very cohesive interdisciplinary team that is on when a patient gets admitted from stroke from the emergency room. It involves the nurses, it involves rehab, all of OT, PT, and ST. It involves the medical residents, it involves the nursing staff is very, very important at this point, as well as additional ancillary staff that are in the hospital as well. And we all collaborate on the cases and work with each other and make sure that we're all focused on getting that patient the ultimate care that is needed to help them get better and better patient outcomes.
So in the emergency room, clearly the emergency room doctor is the pivotal person.
Sure.
On the floor, the team, and the team is headed maybe by a neurologist, but we're all equals. The registered nurse, in my opinion, is always the one who knows the patient best.
It's true.
And the RN tells us if someone is doing better or worse, how their night was. But I think one part that we didn't emphasize enough was part of the team really is the family. Nobody knows their loved one better than they do. They know if they're in a bad mood, if they're not feeling well, if their speech is not as good as it was before. And those clues are crucial. Even something as subtle as someone who's had a stroke and becomes depressed, the idea of letting the physicians and the nurses know about it really allows us to do a lot more. Especially if someone might not speak English as a first language or have some problems with speech, the emotional support from the family is really as important as any other of the groups that we talked about. So we talked about the doctors, and the treatments that we have. We talked about the nurse being aware and tendering care. Do people with a stroke, should they lie in bed? What should happen to them? Should they just be in a bed and just be quiet there?
No. Most of the therapy that we initiate, we try to, once we stabilize the patient and deem them whether or not they have weaknesses with the help of the rehab team, we get them out of bed to the chair within the first 24 hours. It's really important to try to, motivate them, keep the circulation going, try to get them back on the road to recovery as quick as possible. Because as you said, depression really can be a setback for these patients because they do now know they have some limitations and they're really concerned about that.
And you're trying to prevent a lot of side effects and complications. If someone is sitting up, they can go to the bathroom easier.
Right.
If someone is sitting up, they take a deeper breath and don't get pneumonia, hopefully. So there's so many things that we're doing that we really do need to mobilize people. So tell me a little bit about physical therapists, occupational therapists, speech therapists. That whole concept, it sounds like 3 different people evaluate the person, the patient. What do they do and what's different about each one of them?
Well, the speech therapist is one of our main characters in this whole portrayal of a patient with stroke. We have to assess for dysphagia. If we're going to give any medication, that's one of the primary things. And dysphagia is a swallowing difficulty. The speech therapist comes in and she does her assessment and she basically advises the doctors and the staff if the patient is able to take medications. Otherwise, we use other alternative measures of dietary intake and for supplementation. Then our occupational therapist deals with hand motion coordination, abilities to do some activities of daily living as well as memory recalls and doing exercises with the patient to try to get them back to a regular level of cognition. Our physical therapist works basically with the actual mobility of the patient, the ability to walk. There's sometimes shuffling. We have to make sure that they can reteach the brain and relearn the brain how to do these functions, which sometimes are lost during stroke activity.
And that's a whole team approach.
Yes, sir.
As we talk about speech, as we talk about swallowing, being able to get back to where you are. So let's go back to the emergency room. The person came in. What do you assess the patient? We do a CAT scan. What kind of medicines, what intervention do you have early on that we can give someone, Matt?
So early on, we have the option if the patient meets the criteria, and we're within that time frame, we can give the clot buster that you mentioned, the TPA. Other medicines that we consider, or if for some reason that choice is not the optimal choice for that patient, we can give a high dose of a medicine called a statin, which a lot of people might know of as an example of Lipitor, for example, plus an aspirin. Old-fashioned aspirin is very important in this circumstance.
So what we're trying to do is keep the artery open with the blood thinning agent or the antiplatelet agent called aspirin. And there's a lot of mechanisms to why drugs like Lipitor, which is a statin, help keep the arteries open. They're anti-inflammatory agents, but giving them early has been shown in a lot of studies to help long-term benefit. So what's our goal? Our goal is for people to do well over time, to become functional, to get back to where they were. Two things get people functional: getting into the hospital early so that we don't extend the stroke. The other is time. That helps heal with recircuiting. And the other are the therapies that we mentioned: the speech therapy, the physical therapy, the occupational therapy, and recognizing if there's any medical complications that are occurring. Recently, and Trish, we've talked about this, there's a new window after the 6 hours where people go in, and there are certain centers that are doing what's called endovascular techniques, where they actually retrieve the clot. So to go over it just a little bit, we have different thoughts about what causes a stroke. And strokes could either be what's called ischemic, which means that a part of the brain has died because of the stroke, or hemorrhagic. And this is a little model of an artery. And when we're young, the artery is wide open, and blood is able to flow through normally, and we do well. Over years, because of certain factors, including high blood pressure, smoking, obesity, high cholesterol, diabetes, and those are things that we have, certain things that we can modify, the arteries get tighter. And this yellow material is a plaque called atherosclerosis. It's made of this lipid yellow material that closes off the hole. So as Matt said, if we give a clot buster, we could dissolve a plaque that's in there. If we give drugs like aspirin or even cholesterol-lowering agents, we sometimes can keep that artery open longer. So that's really what the goal of therapies are. But recently there's been some wonderful, wonderful studies showing that if you go in there with certain devices within a 6 to 8 hour window, you can actually pull out the clot. And that's really what's happening and what different centers are trying to achieve in order to give people the best chance of making a functional recovery. As we said, stroke is the #1 cause of disability in the United States because people are left with such disability for such a long period of time. Maybe just going back to stroke a little bit. Are all strokes the same? If you think about it, do kids get strokes? Do teenagers get strokes? Are they different than others?
So we usually think about strokes in elderly people, or at least middle-aged people, not so much in kids or young adults, but we do see it in kids and young adults as well. There can be certain underlying conditions, such as someone who their bloods tend to clot a little more than normal, or underlying conditions such as lupus, for example. You can see patients very young having strokes. So it's important to recognize in those age groups as well. Other causes may be recreational drugs. Cocaine can raise the blood pressure and precipitate a stroke, and we have seen that certainly. But again, it's important for both the providers and the family members and the patients themselves to recognize that even young people are at risk. If they do present with these symptoms, they should consider that they may be having a stroke. And again, getting back to your point about family, really the family is a key part in all of, and where it all starts. And oftentimes, the family member is the person who identifies the deficit and who encourages that patient to get to the ER as soon as possible. And oftentimes when they present to the ER, the family member is the person who gives us all the information that we need to make that decision very quickly.
No, that's very well said. You think of Uncle John who's having some chest discomfort and says, I'm not going to the hospital. It takes somebody at that family table to say, or family room to say, you have to go.
Yeah.
And that's what we have to do with this also. And there's been a lot of programs on Staten Island where they had children being taught about stroke. And in case there's a problem with one of their parents or grandparents, uncles or aunts or family members, to recognize this whole process that's going on. But what I think is so interesting is that even neonates could have a stroke. And that happens sometimes because of bleeding problems like sickle cell anemia, sometimes related to an artery not growing normally. Cerebral palsy could be on the basis of a stroke. You mentioned cocaine, amphetamine use, so if someone in their 20s comes in, we're always worried about drug use. Someone older, we talk about atherosclerosis, where we deal with cholesterol plaques. So every person is different, and every workup is different. So someone who comes in with a stroke doesn't get this whole model, you have to get X, Y, Z. We've got certain ideas of what we're going to do, but everyone is different. Somebody who might have had trauma to their neck can get a stroke. There have been some famous cases lately of things like that. So everyone is unique, and you really have to look at every individual. And that's why we do so well with a team approach. The family says things to the nurse or says something to the nutritionist. Something is conveyed that sometimes gives us the clue as to what caused a stroke in that person. Let's talk a little bit about some newfangled ambulances. So there's been a lot of things going on in the world, and I hear they have ambulances that have all kinds of machinery on them in order to treat people quicker. Tell me about them. What do you think?
So there is certainly a shift of a lot of greater abilities and sophistication in the ambulances themselves. And this is in a number of different conditions, but stroke, as we mentioned, time is so important in these patients that there are some studies and new programs where ambulances actually have the ability to image and evaluate and do CAT scans on patients before they even get to the hospital. So that way there's an entire step that's already addressed. So we know by the time they get to the ED, the emergency department, we have a jump start on what to do for that patient. Again, saving time.
And I think Trish and I always use the term through the American Heart Association called the golden hour. Even if we have 3 hours, 1 hour is better.
Yes.
You know, sometimes you think in the old days we used to say, well, I have 3 hours. So most of the people were getting treatment at 2 hours and 59 minutes. Answer is at 10 minutes it's better, at 1 hour it's better. It's every moment you go, the worse it gets. So the earlier you could do, it's better than waiting for that full 3 hours. So Trish, we're talking about around the country something called telemedicine, telestroke. In rural areas, what do you do if you can't get to a hospital in 3 hours? And there are places like that. What kind of things are available to people, and what kind of things, even in this country here, in our county, in areas, sometimes people can't get places quick enough. What kind of things are out there about telestroke?
Telestroke and telemedicine has been really a way that the doctors and neurologists can evaluate the patient before they get to a facility, but at least you could see how the patient is doing. They can measure blood pressures, they can monitor the patient. It helps for the assessment of the patient and facilitate what has to be done immediately. But the main thing is to get that patient to a facility. But again, it is a direct impression of the patient at the time of event, which really a lot of the home care agencies are implementing as well. It's very important.
I think it's so interesting that you could have through a video camera a doctor in a different town, state, country, assess you, and they talk back and forth. And I've done this numerous times. We've been asked to do this around the country. And if somebody at a different time zone and they live far away, EMS or any healthcare professional with some of these, with the advent of what's going on there and an imaging study like a CAT scan, can give these newer treatments that are available. And even on Staten Island, that we have a lot of treatments, there are some that we don't have. And we send patients out for certain procedures that have to be done. And through telemedicine, those doctors are able to see what's going on with our patients. That really has tremendous advantages. It's nice to see that technology has really caught up so much with what's going on in the real world and be able to give people a better understanding. I'm going to editorialize for a couple of seconds and basically say how proud I am of the group that we have. I mean, Tricia, you do such a wonderful job. Matt and the entire emergency room. The idea that everyone works as a cohesive unit is marvelous. And that happens with most stroke centers. And there's another stroke center over at Staten Island University Hospital. So Staten Island has a lot of stroke centers. There's two major ones, Staten Island Hospital North and also us at Richmond University Medical Center. And the idea that we're able to provide the 500,000 people on Staten Island with cutting edge stroke care right now, and if things aren't available to us, and some things aren't, the availability and ability to get someone to another center in order to get the best of care that we need. Tell me a little bit about what you think about the team approach. I mean, how does that help? How does that help the individual? If somebody comes in, who talks to the family? How many people are there to be involved with that one person?
The team approach is very integral when regarding a stroke patient. We collaborate and on the patient care. It helps the patient to want to participate and get well from the stroke activity and the stroke situation that they had incurred. Each member of the team communicates in a very, very specific manner, and the main focus is to get that patient back to a functional status. So, you know, it is a very, very intertwined, should I say, effort that is to help the patient. And I think it's the best vantage point for the patient that everybody knows about the case at the same time as we collaborate on the case. And we all know that the main thing is to make sure that we can get to that patient to a special functional status, and if not, we actually would provide additional care in the community for that patient as well. So everybody participates in this effect, and is the most effective way to do any kind of nursing, I think, at this point.
And you also said with the social worker helping get everything
Yes,
ready
sir.
in the community. But does it help? I mean, all the data out there, and you tell me this almost on a daily basis.
It definitely
what
does.
does it help?
What
does
it
it
definitely
help?
helps the patient, because the patient feels that they're also participant in their care by being part of the team. And that is very important in somebody who has a stroke, because again, they don't understand what is going on. They don't understand what initially happens to them. Now they're part of this team effort to make them better and to make sure that they get to their ultimate status of what they were previous to the event. So they do feel that it benefits them to be part of this team too. So that's why I think it always works. It seems to always work.
And it's funny, with every field of medicine, specialty centers do better. Whether it's centers for cancer treatment, kidney treatment, heart treatment. And in our stroke center, what we always see, what we have seen statistically over the last 20 years that these centers have existed, is that people stay in the hospital less time, therefore there's less risk for infection, and functionally they do better. So it's amazing to think that just because the team is involved and people are looking at you, people do better. And that's really what we're here for tonight, to be able to talk to the community on Staten Island, to say, get to the hospital, because we all want you to have a better outcome. And if you have a better outcome, it'll be better for you, better for your family, and better for everyone. And the team approach is really what does everything with this. Having different people involved with different specialties, different things that we could do really has made stroke centers a major part. Stroke education is crucial.
It is very
and
crucial.
as I say, I'll say in concluding, I'm really so proud of the group that we deal with, that we are part of at Richmond University Medical Center.
Thank you.
So thank you all.
Thank you, sir.